Hello, welcome to a new edition of our GIDE Unlocked podcast. This is Dr. Sascha Jovanovic here from Los Angeles. I have the honor and the pleasure today to be together with Dr. José Carlos da Rosa from Brazil, and I'm so thrilled to have you here because he's going to bring to us a new, very innovative procedure for our patients, especially for the compromised socket, called the IDR Protocol. Welcome, José Carlos.
Thanks for having me here. It's a great pleasure and honor to be part of the GIDE meeting. For me, it's going to be an amazing experience to share my knowledge, to share my experience with the audience.
About 20 years ago, José Carlos and we met, and obviously you are working in an area which is very, very important for us, the compromised socket. And we're dealing today with a lot of requests from doctors and from industry about doing immediate implants in sockets. So first of all, tell us maybe your journey a little bit, because obviously you've been working in implants, you've been working with tissues, you're a specialist in implants, perio and pros, so your pedigree is very strong. So how did you start this journey? Because it is a very unique treatment that you're doing.
Yeah, I've been working with this project for more than 20 years. The first implant that I placed in the socket was in the end of 90s, and I apply not IDR technique, but I made my provisional restoration immediately without putting anything inside the socket. We didn't know. Nobody knew at that time how to manage this. So what we learned in the last 20 years when we start applying this approach, we are able to put, right after tooth extraction, we remove the tissue granulation, we put the implant in the correct dimensional position, we perform the provisional restoration immediately with ideal emergence profile, and we only use autogenous bone tissue, hard tissue, or sometimes hard and soft tissue harvest from the maxillary tuberosity. And what we've seen in the last 20 years is about the soft tissue stability around the implant placement. So when we focus on that, since the beginning, we start applying this methodology only for such a case that was missing the buccal wall. A couple of years later, we realized that we need to go one step further. And we cross a little bit the boundaries, because we start applying this technique for such a case that was missing two walls, buccal and the palatal. And we realized, that's great. We succeed again. So let's go one step ahead. And we start applying this technique for cases that was missing 3 walls, 4 walls. And then we realized, no, I think we can not only rebuild the buccal and the palatal wall, but also the mesial and the distal bone ridge. This is a big mess in the periodontology to be repaired.
So basically also to support the interproximal gingival papilla?
Yes, and to perform the bone growth in between the implant and the natural tooth. Doesn't matter if this implant is placed with the bone defect in one side or on both sides. We can do it in one single procedure without opening the flap.
So tell us maybe a little bit, because that's kind of interests me as well, and our audience is like, obviously implant dentistry is a very traditional therapy. Already immediate implants was a controversial topic for many years. Yes. I remember probably 20-25 years ago, some groups in implant dentistry didn't even accept immediate implants. Yeah. So you were working at that time already with like a very, let's say, forward-thinking procedure. How did you kind of survive that period? Because obviously there must have been a lot of people who were trying to, cut your chairs. So did you just believe in this technique, or did you really see these early results and you were like surprised? What was it? What kept you going?
So I would say that the results were absolutely outstanding. But not only that. When I realized that I was in the right way, I developed the protocols. I think that's why I realized that we need to go in this direction. According to the protocol that we developed, if you follow the protocol, this is the outcomes that the patients are really looking for, because we can keep the gingival architecture in its original position. But we didn't do it since the beginning. So we created maturity in order to go beyond the boundaries in order to apply this technique for such a very challenging clinical case. So first, we develop the protocols. And then we start writing papers and doing some research about the soft tissue and hard tissue stability along the months and along the years. We have several papers with long-term follow-up. So after that, we start applying this technique and doing with different protocols. For such a case, for example, that's missing the buccal wall, and we have the combination with ginger recession, or for cases that's missing the buccal wall in combination with papillary loss. That's a nightmare for everybody. And we develop protocols for this. So IDR technique is all based on street protocols. What I would usually say for the beginners, don't apply this technique if you are not ready yet. Mm-hmm. The only way to apply this technique, you should come for some IDR courses to make the training, because I need to hold your hands in order to let you know what's the best way to go. And then when we finish the training, you are ready to apply this technique first, as you are a beginner, for such a case that's missing buccal wall.
Okay, so let's maybe go, attention to detail and clinical handling is very, very important. But what I understand is, like, in this new world we are in, you know how there's a lot of pressure on immediate implants. Yeah. There's a lot of pressure on not harming the patient, using biomaterials. But the way you develop this protocol and the way you are applying this protocol for your patients is, like, if I'm understanding this correctly, it's 100% autogenous bone, mm-hmm. and it's 100% soft tissue. Is that correct?
Yes. From the same donor side, from the maxillary tuberosity. What we've seen is not only the predictability of the outcomes, but also about the complaints. When you harvest, for example, soft tissue from the palatal, patient is always complaining about something. Pain, it was very painful. But when we harvest bone and soft tissue from the tuberosity, this is one more advantage, because patients don't complain about swelling, pain, and anything. In the postoperative week, they will not suffer anything. So this is one more advantages of using this approach. Instead of taking soft tissue from the palatal, we would prefer to take soft tissue from the tuberosity. And we start doing some research in order to make a comparison between soft tissue from the palate and from the tuberosity. And we notice lots of advantages of soft tissue from the tuberosity when make a comparison with soft tissue from the palate. This is one more reasons that we realized that we were in the right direction.
Okay. So then, obviously we have cases that are very typical, which is the central incisor fracture, central incisor maybe apical infection. But now many times we also have patients who have multiple compromised sockets. So I'm sure you started with one tooth, but where is there a limit? Can we, like, do this, like, in multiple teeth, or do you say, like, hey, definitely start with one tooth and then slowly go up? But what's the limit?
Yeah. We start in the beginning with one single tooth for sure. As soon as we realize about the protocol, we start applying in order to replace 2 central incisors, for example, and then 3, and then 4, and then we went step by step. Mm-hmm. But if you ask me, José Carlos, what's the limit? I would say that this is a super humble answer, but we are still looking for.
Okay. That's
because of what? Because we developed different protocols to be used for such a case that we have no walls around the condemned tooth, and sometimes not only no walls around the condemned tooth, but no remaining bone at the apex. So, after we developed these new protocols, we realized, I can go one step ahead. And then we went step by step. We didn't create this since the beginning, and we didn't change. We are always updating the technique. Okay, right. I think this is one of the main reasons that the people realize that, I think we need to keep an eye on that. And nowadays we have thousands of dentists worldwide applying this technique and get the same outcomes. That's that's why I'm super happy about this technique.
Well, and I think this is also a very important thing. Like I had the same thing when, with the GBR technique. I was so happy that GBR, of course, became a global standard. But at the same time, every time we did a training program with GBR, you see, of course, like some clinicians who are better and some clinicians are maybe not as good. And you can see how the GBR technique is very dependent on the handling, the talent, and just, the management of the tissues. So your technique, which we, of course, call the IDR technique, how technique sensitive is it for, like, let's say, a good dentist? Well, I'm not talking about an average dentist, a good dentist.
A good dentist. I would say that is a technique sensitive as GBR is a technique sensitive. So that technique sensitive demands training. That's why I will recommend you for all the beginners to start from the simplest clinical case. It's because your learning curve is much more important than the outcome. As soon as you get much more experience, you are going to apply this technique for those much more challenged clinical cases. But before that, don't do it. If you fail, you won't believe in the technique. But the problem is not the technique itself. It's because you are not prepared for this battle, for this such a very challenged clinical case. In GBR, what do you recommend for the beginners? To start from the simplest clinical case ever. And then you go one step further and you start crossing the boundaries and to apply this technique to replace 2 teeth, 3 teeth, and so on. Yeah. It's absolutely the same approach.
Talk a little bit about immediate implants, right? Because obviously your technique is kind of built around immediate implants and also giving a patient immediate temporaries. Do you feel like, living in Brazil, but also traveling the world, that the field of immediate implants, is that a pressure that's put on us from the clinicians and maybe from industry, or are you really feeling that the patients want this technique? I'm trying to find out, how far do we need to go with immediate implants? Do we need to go so fast?
Yes, I think this is what the patients are really looking for, to make the cost of treatment much less.
Do you think the cost of treatment is less?
Yes, much less. But also to deliver for the patient a faster treatment. So according to my opinion, this is what the patients are really looking for, especially in South America, because the cost of the treatment when we use, for example, GBR is much more costly. So we need to
more materials.
More material you need. In IDR technique, we only use autogenous. You don't use any kind of bond substitute, for example. So it makes a lot of difference, not only in South America, but worldwide. This is one more reasons that the patients are coming in this direction in order to learn as much as possible this new concept, because it will make their daily practice differently and they will get very nice outcomes in the management of compromised sockets.
Okay, so then I have so many questions, so I apologize, of course, but I think the audience is definitely learning and going with us. So let's talk about contraindications, because your technique has a little bit of a risk that clinicians are going to look at this here and they're going to say, oh my God, José Carlos was doing buccal loss, apical infection, palatal loss, 3-dimensional papilla, it's everything. So you already defined like somebody should start small, but where's the contraindication?
I think the main contraindications is for those cases that we don't have enough bone at the tuberosity. We just launched a paper that we define exactly in which area we are going to take the bone, the 360 degree. So in other words, we learn that we can take the bone. In the past, we used it to take the bone just behind the last tooth. Doesn't matter if it was the second molar or the third molar. But as soon as our learning curve grows like this, we realize, no, we can take the bone not only for that specific donor side, but we can take the bone 360 degree around the last teeth. In other words, we can take the bone from behind the last tooth, from the buccal aspect of the last tooth, the palatal aspect of the last tooth, in between the two last teeth. So if you think in this way, you increase a lot the amount of bone harvest from the maxillary tuberosity. This is going to be the main indications of not using this approach. When we don't find the bone, what's our job? To let the dentist know how to realize, to figure out where the bone is placed, how to take it, what's the best tool to be used in order to harvest the bone in the safest way possible, but not only to take the bone behind the last tooth, but 360 degrees around the last teeth. You asked me about the infection. When we have the presence of the infection, according to our protocol, we prescribe antibiotic therapy 5 days prior to the procedure. If for some reason we are facing with large periapical lesion like this and didn't work, what I would recommend you, don't cancel the surgery, but change a little bit the protocol. You can add connective tissue graft like an envelope in order to protect the bone tissue that you are going to leave underneath the connective tissue. So if you use this approach, you will protect the bone graft and the outcome is going to be absolutely the same. This is one of the issues, the complications that we had, but we didn't know. We were in the beginning of the developing process of this technique, but when we realized the needs of using the CT graft, it changed completely the scenario.
Also, like a contraindication possibly, if you have a tooth, compromised tooth, we're going to extract it, you have no buccal bone, and you have a fistula. Do you feel the IDR technique is still a potential for success?
This is one more indications for CT graft. For such a case that we have the presence of the fistula, if you are able to control the fistula, take some medicine like antibiotic therapy prior to the surgery, you don't need to use CT graft. But if you cannot control, it's mandatory to use. I just remember one more strategy that you can use in order to augment, to increase the volume of the bone at the tuberosity. You can extract, for example, the wisdom tooth when it's indicated prior to the surgery, 3 months before. And you are going to augment the volume of the bone available, and you can wait a little bit more. If for some reason we have the presence of the fracture, we are going to bond the condemned tooth in the neighboring teeth in order to keep the gingival architecture, to control the infection, and to wait for 3 months. And then we are going to perform the surgery. We have lots of cases that we use this strategy, and this is really amazing.
Okay. You mentioned a little bit like your pharmacological regimen that you use for these patients. I mean, I assume that you have a normal routine regimen, like
Absolutely.
antibiotics.
Normal.
And then chlorhexidine rinsing and all the normal. Anything special there?
Nothing special.
Okay. Tell us about periodontal health on patients. Again, I assume that your patients are all like super clean and have no periodontal disease, or is there anything?
We need to control first when we have some compromised tooth, the periodontal disease, to put those patients under periodontal treatment, and then you are going to perform the IDR technique, because we need to work with in such a health tissue, a health mouth, instead of take the tooth out with a big mass in his patient's mouth. So we need to control first the quality of the hygiene first in order to keep them as motivated as possible, because in a couple of weeks they are going to receive the IDR technique, and I will dream like an angel if they clean accurately. If they don't clean, it's going to be very bad for me and for them.
We're going to wrap it up, but a couple of fun facts here. How many countries have you been in the world that you have been teaching your IDR protocol?
In 61 countries.
61.
61.
How many textbooks have you written at this moment?
I wrote the first edition of the IDR technique. It was published first in Portuguese in 2010, and we converted in English language in 2014. And last year it was launched the second edition in English language. It was a great success in the quintessence. It's one of the best-selling books worldwide. And now we are working on another project.
Third one, okay.
It's all about the tuberosity and its indications.
Third book.
The third book. And then I think it's time to start.
How many, let's say, IDR cases have you done so far?
Oh, nice. Very nice question. I've already performed more than 1,000 clinical cases that was missing 1 wall, 2 walls, 3 all walls around the condemned tooth in combination or not with ginger recession and the papillar loss. So that's why we create the maturity to be here with you today and to let them know another possibility, alternative of treatment of them in the management of compromised sockets.
When you speak to a patient and the patient says, what's your success rate, Dr. José Carlos? What do you tell them?
I would say not only for the patient, but also for the dentist. If you follow the rules, you will succeed. If you don't follow, if you try to jump some steps, there are lots of dentists worldwide that they can change something. I did all the changes in the past, and I did not succeed. That's why I start following the protocol that we developed. If you follow the protocol, you succeed.
Great. So, well, we're going to want to thank you. This is like, an enlightening podcast for the gIDE Unlocked. Definitely like an absolutely thought-provoking, not a new procedure, because obviously you've been working on this for a long time, but that's what happens, right? We have the trailblazers in the industry like you who is pushing the field forward. And I'm personally very, very impressed with your dedication to the field. And it's great that you're coming to us from Brazil. Safe trip back.
Thank you so much.
Honestly, I cannot wait for you to come back to California. And we can do like next time, maybe you can bring some wine from Brazil and we can like taste the difference between California wine and Brazilian wine.
That's a good news. Thank you so much.
Thank you so much.
Thank you so much.
Thank you.
Thank you.